old and new terminology, which can be a little bit confusing. Hello? And then learn how to care for patients with epilepsy. Okay, so I was asked to try to do a case presentation as much as I can, so we'll follow this one patient through. So you have a 25-year-old woman who comes to you because she's been having episodes of losing awareness for the past year. She says she typically experiences an unpleasant smell, and then she loses awareness. And she's been told that she's out of it for 1 to 2 minutes. And she's been told that she seems to stare during the episode. And then typically she'll kind of gradually regain her awareness, come to, but sometimes she will then fall to the ground and have convulsive movements lasting 1 to 3 minutes, and she's out of it for a little while after that. And there are no apparent triggers for her episode. Okay? So you're seeing her in the office or in the clinic. Okay. So question number 1, so what is her diagnosis? And if seizures, what types of seizures does she have? And does she have epilepsy? Does she meet the criteria for epilepsy? Okay, so let's start with definitions. So what is a seizure? There are lots of different definitions, but I like this one. Seizure is a transient occurrence of signs and or symptoms due to an abnormal, excessive, or synchronous neuronal activity in the brain. So basically, it's an abnormal electrical discharge in the brain. Depending on where in the brain that discharge occurs, or how much of the brain is involved in that discharge, you're going to get different kinds of seizures. Now, you can get seizures for a variety of reasons, but when somebody presents to you with seizures, the most important thing is to distinguish provoked seizures from unprovoked seizures. Okay? Sometimes provoked seizures are called acute symptomatic seizures. So with provoked seizures, what that means is that there is a specific trigger for that seizure. So every seizure has a specific trigger. So a common example would be that somebody does cocaine. They have a seizure after doing cocaine. Every time they do cocaine, they have a seizure. That's a cocaine-induced seizure trigger. Or you have an alcoholic, and every time he stops drinking, he has a withdrawal seizure. That's a provoked seizure due to alcohol withdrawal. Unless you can get seizures due to acute head injury within the first 7 days, or encephalitis and so forth. You have to distinguish that from unprovoked seizure, which means that there is no specific trigger for every single seizure. You can still have risk factors to have seizures, but it's not an acute trigger. So it used to be called remote symptomatic seizures. So what that means is that, for example, somebody might have had an old stroke 5 years ago, and then now she starts having seizures. Obviously, the stroke is the cause for this person's recurrent seizures, but it's not an acute precipitant for every single seizure. All right. So then, if that's seizure, what's epilepsy? Well, seizure is a symptom. It's like having a cough. Just because you have a cough doesn't mean that you have pneumonia. It could be bronchitis, whatever it might be. Well, if you have a seizure, it could be due to a lot of different causes. Epilepsy is a chronic condition that's characterized by having recurrent, unprovoked seizures. Now, the definition of epilepsy used to be pretty simple. It was the first bullet. You had to have at least 2 unprovoked seizures, at least 24 hours apart. If you had 2 seizures within 24 hours, that was counted as 1 seizure. So the person did not meet the definition of epilepsy. And there was no required time frame. So you could have 1 seizure, and then have one 10 years later, and then at that point, you'd be diagnosed with epilepsy. Well, a few years ago, they modified the definition to include 2 other bullets. With the old definition, when you had 2 unprovoked seizures, if you had 2 unprovoked seizures, chance of you having a 3rd unprovoked seizure without treatment was at least 60%. So with this new definition, they added that if you had 1 unprovoked seizure, but your workup reveals things such that chance of you having a 2nd seizure was at least 60%, then you can make the diagnosis of epilepsy. So it's as if you've already had the seizure, so to speak. The problem is they didn't define how to get to that 60% on a practical level. And so generally what that means is that if you have one unprovoked seizure and you have an abnormal EEG that demonstrates epileptiform activity and or brain imaging study that shows a discrete lesion that could cause seizures, that's probably enough to get you over that 60% mark. So somebody comes in, let's say, with the first seizure, and you do an MRI and have a meningioma. That's probably enough to tip you over the 60% mark, and you can make the diagnosis of epilepsy. The second bullet point they added was if you're able to diagnose a specific genetic epilepsy syndrome based on the one seizure. And sometimes you can do that, although in practice it's not always so easy to do. And then I guess following sort of the oncology field, they also came up with this last thing where epilepsy is considered resolved, not cured, but resolved if you have an age-dependent epilepsy syndrome and you've outgrown that syndrome, basically, you've passed that age, or you remain seizure-free for at least 10 years and off medicines for 5 years. Okay, so if you're seizure-free for 10 years, of which 5 you're off medicines, then your epilepsy is considered resolved. I'd like to throw this up there. This is just an incidence curve of epilepsy. It's kind of a U-shaped curve. I'd like to point this out is because when someone's diagnosed with epilepsy, especially adult onset epilepsy, they always go, wait, isn't epilepsy like a childhood disorder? I mean, why am I getting it now that I'm 40 years old or 30 years old? Okay. But this curve shows you that you can develop epilepsy at any age. Okay? Yes, the peak is higher during infancy and childhood, also in the elderly population, but the risk never goes down to zero. Okay? So epilepsy can occur at any age. When you develop it at a younger age, it generally tends to be more genetic in etiology. Okay? Later on, it tends to be more acute symptomatic, so prior brain injury, prior stroke, what have you. By the way, chance of any one of us getting a single seizure in our lifetime is about 10%. So it's not a small number. Epilepsy prevalence is about 1% in the world. Okay. Now I'm going to go through this quickly and then go in more detail in a few slides, but I feel like I have to go through both because there's been a change in terminology when it comes to seizures and epilepsy. So before, seizures were split into what we call partial, sometimes they were called focal seizures, and generalized seizures. And it depended on how that electrical abnormality began and where it began in the brain. And you had these subtypes, so people were aware of simple partial, complex partial seizures, and so forth. Well, that's old terminology now. So a couple years ago, the International League Against Epilepsy, which is the World Parent Epilepsy Organization, came up with a new classification scheme and new terminology. So they got rid of the term simple partial, complex partial. In fact, they got rid of the term partial seizures completely because they felt that the term partial was confusing to patients and family members. It sort of implied that it was not a full seizure, but part of a seizure. So they got rid of the term partial and replaced it with focal. And they thought the term complex versus simple was also confusing. So they said, let's call it focal seizures with awareness, so intact awareness or impaired awareness. Okay? And the focal seizure could then spread to convulsive seizure. It used to be called secondarily generalized tonic-clonic seizures. Now they rephrase it as focal bilateral tonic-clonic seizures, trying to make it so more kind of plain English in terms of description. They left the generalized onset seizures alone, so that term still applies. And then they expanded it so that I guess you guys don't really have to worry about this. This is really more for the neurologists and maybe epileptologists. You can subdivide each focal to whether the predominant symptom is motor or non-motor, and then subdivide it and so forth. But you guys don't have to really worry about that. But just be aware that that's called focal aware and focal impaired aware seizures as opposed to simple partial versus complex partial seizures. Okay. Now, if you have recurrent seizures and you have epilepsy, this is the old epilepsy syndrome, and you may still hear the terminology, so I'm just bringing it there real quickly, but a little bit confusing because partial epilepsy or focal epilepsy was actually officially called localization-related epilepsy. Okay, so sometimes you'll see abbreviation LR epilepsy or LRE, but localization-related epilepsy means focal epilepsy or partial epilepsy. And then generalized episy is this same thing. what was confusing was the sort of the subcategory. These terms really refer to the presumed etiology of the person's epilepsy. And so when you said somebody had idiopathic epilepsy, you were actually implying a genetic cause, which makes no sense. If you truly thought that it was idiopathic, the term cryptogenic was used. Okay. Symptomatic means that there's a trigger or a risk factor to develop epilepsy. So if somebody had an old stroke and developed seizures later on, that the person has symptomatic epilepsy due to the old stroke. So with the new classification scheme, they got rid of subcategories, and so if you have recurrent focal seizures, then you have focal epilepsy, generalized seizures, you have generalized epilepsy, which is fine, and then you broke down the etiology into more sensical terms, due to a structural lesion, or it was genetic in origin, due to infectious etiology, and so forth. And they left the epilepsy syndromes, which are primarily genetic in origin. They left that category alone. All right, so let's talk about seizure types in more detail. So when they came up with a new schema and new terminology, they also kind of tried to change the conceptualization of what a focal seizure was based on not only clinical, but also electrophysiologic and imaging data. And so this is their definition. But they're saying that focal epileptic seizures are conceptualized as originating within a network limited to one hemisphere. And that network could be very specifically localized within that hemisphere, or could be more widely spread within that hemisphere. And so the idea would be that you have some epileptogenic focus, and that somehow activates the local epileptogenic network in that region. Sometimes this can then spread to involve both hemispheres. So you have focus of bilateral tonic-clonic, so bilateral involvement. There are really two, maybe three types of focal seizures. So you got the focal aware, which used to be called simple partial. You got focal impaired awareness, which used to be called complex partial. And then you have focal to bilateral tonic-clonic, which used to be called secondarily generalized tonic-clonic. So go through these different subtypes in a little bit more detail. So a focal aware seizure, simple partial seizure. How do you make that diagnosis? Well, bullet point number one. So during the seizure activity, the person is fully awake and alert. So they're conscious, they can hear you, they can interact normally, and so forth. So there's no impairment of awareness to any degree. If somebody's a little bit slow, a little bit confused, then that knocks you over to the impaired awareness category. Again, depending on where that seizure discharges in the brain, you can get a variety of symptoms during a simple focal aware seizures. The most common thing is the focal motor seizure. But you can get sensory seizures, you can get autonomic seizures like nerve palpitations, unless you can get like a phenomena like recurrent deja vu, for example. But as you can imagine, consciousness or awareness is impacted during a focal aware seizure because the amount of brain tissue that's involved in that abnormal electrical discharge is very limited. So because of that, if you were to do an EEG during a focal aware seizure, the scalp EEG may be normal because the discharge is so confined and so small, the scalp electrode may not be able to pick up that discharge. If you had electrodes directly in the brain or on the brain surface, then you would pick it up, sure. And so the point is that if you think somebody's having focal aware seizures, and they have one during an EEG, and the EEG report comes back normal, it does not exclude the diagnosis of focal aware seizures. Now, if that discharge involves to spread a larger region of the brain, then the focal aware seizures can evolve into focal unaware or impaired awareness seizure. If it spreads to both hemispheres, then you get bilateral tonic-clonic. Focal impaired awareness seizures, the old complex partial seizures. So by definition, you have to have impairment of consciousness or awareness. They could completely blank out, be completely amnestic for the episode, or they could be just a little bit slow. So they're not responding normally, but they can still respond. They're just a little bit not right. So any degree of impairment would flip it into this diagnosis. Now, focal impaired awareness seizures are the most common type of seizures, statistically. They tend to last about 1, maybe 2 minutes in duration, typically. And if you're to witness somebody having a focal impaired awareness seizure, they look like they're out of it, they're staring, they look a little confused. They may have automatisms, which are automatic, non-purposeful behaviors. So examples of simple automatisms would be like smacking, making chewing movements, eye fluttering, and so forth. Sometimes they can have so-called reactive automatisms, which are kind of rudimentary reaction to environmental cues. So somebody's having a focal impaired awareness seizure, and you talk to them, are you okay? They may kind of nod back to you, perhaps. Or if you hand them something, they may actually reach out and grab it. Right? But there's no purposeful meaning to the movement. It's kind of a reaction. Patients are typically amnesic for the actual ictal event, for the actual seizure in and of itself. Again, depends on how much they're impaired. They may have patchy recall, but they don't have complete recall of the entire event. And unlike a focal aware seizure, if you were to do an EEG during a focal impaired aware seizure, the scalp EEG will almost always be abnormal. There are caveats because there are certain regions of the brain that's not well captured on a scalp EEG. So if somebody has occipital onset seizures or frontal onset, sometimes those can be missed. But as a general rule, the scalp EEG should be abnormal. So if somebody has what looks like a focal impaired aware seizure during an EEG, and the EEG is completely normal, then the odds are it wasn't a focal impaired aware seizure. And you have to kind of rethink your diagnosis. Sometimes focal impaired awareness seizures, by the way, it's a mouthful. I find complex partially easier to say. Maybe I'm just old. It can be preceded by an aura, which is a warning. Okay? When somebody has an aura, typically what that means is that the electrical discharge has already begun in the brain. And the common auras are you may smell something. It's an unpleasant smell. They'll say it's like a burning rubber, that kind of smell. You may have psychic phenomena like deja vu is very common as an aura. And then there's often what's called an epigastric aura, where they feel something kind of funny in the stomach, maybe a discomfort, maybe like a butterfly sensation. They'll often describe as kind of a rising sensation that comes up in their chest before they lose awareness. And again, any kind of focal seizure can then progress to a bilateral tonic-clonic if it stimulates the epigenetic network in both hemispheres. And it's the same thing. So you can go from focal aware directly into bilateral tonic-clonic, or focal impaired awareness, or focal unaware bilateral tonic-clonic. Okay. So that's it. Those are the focal seizures. So you got focal aware, focal impaired awareness. Pretty easy. So generalized seizures. So this was also reconceptualized when they were coming up with a new schema. And again, this is based on a lot of the sort of scientific data that we've learned over the decades since the prior classification. So generalized seizures are conceptualized as originating at some point within, but rapidly engaging by laterally distributed networks based on cortical and subcortical structures, but it doesn't have to involve the entire cortex. The significance of this conceptualization is that this implies that there could be a specific focus that triggers bilateral networks simultaneously. So in other words, a focal lesion then could theoretically cause generalized seizures, what used to be called primary generalized seizures. And so you got this kind of widely distributed network involving both hemispheres, but that network could be triggered or activated by focus. It could be, in this case, the left frontal or right occipital. And so, because we've known, for example, in some situations where a person has what looks like generalized seizures, but then there's a focal lesion that causes it, if you resect it, then it's up better. All right, so types of generalized seizures. So I'm sort of taking this from the old classification scheme just for simplicity's sake, because with the new scheme, in terms of generalized seizures, there can be kind of overlap. But I think that for the purpose of this talk, it's just easier to using the old schema and go through these. Generalized seizures tend to be less common than focal seizures. In terms of epilepsies, a third of the epilepsies are generalized, two-thirds are focal. Generalized epilepsies tend to be more genetic in etiology, and therefore it's more common in kids. Okay? It's more associated with a lot of the age-dependent syndromes. And because it's genetic, there may be a stronger family history in those patients. Okay, so absence seizures, so-called petit mal seizures. Now, the term petit mal, as opposed to grand mal, is an old term, and sometimes you'll still hear it from old timers or from patients who've had epilepsy for decades. They say, I was told I had petit mal. The problem with that term, you shouldn't use it at all because petit mal was initially used to describe absence seizures. What happened was over the years, people started using it loosely, and they meant either absence seizures or focal impaired awareness seizure. Okay. And the problem with that is that it affects possibly prognosis, affects treatment, because some medicines will actually help focal impaired awareness but aggravate absence seizures, and so you have to really distinguish the two to make sure that you weren't harming the patient. Okay, so with absence seizures, which people often confuse with focal impaired awareness. They say, what's the difference? Well, there's a lot different. So clinically, absence seizures tend to be much briefer. So you're talking about in the order of seconds. I put 10 to 20 seconds here, but it could be 3 seconds. Okay, so the point being that it's in the order of seconds, unlike focal impaired awareness seizures where it's in the order of minutes. During both, person may look like they're staring. But unlike the focal impaired aware seizure, there's no particular recovery period after the absence seizure. So it's like turning on and off the light switch. When the seizure comes on, person stares for a second, you discharge in, the person's back to normal right away. Whereas focal impaired awareness seizures, even after the seizure discharge ends, there's some recovery period. So it may take a minute or two or longer for the patient to fully come back to his normal self. People can have subtle, myoclonic. They can have simple automatisms during absence seizures, typically lip smacking or eye fluttering. But again, there's no aura, no recovery period, and it lasts seconds. GTCs, the so-called grand mal, everybody knows about this. It is called GTC, but there really are two phases. There's the tonic phase, followed by the clonic phase. Okay, so a true GTC really has both phases. During a GTC, person always loses consciousness. Somebody's having an apparent GTC and they're awake, and they're not having a GTC, so big red flag. Typically what happens is a person will fall, there's the initial tonic phase, and during that phase, the person may look a little cyanotic, and so that's when the patient's family members or friends usually freak out. The patient's going to die. And it's followed by rhythmic jerking. When they have rhythmic jerking, it really is rhythmic, and it's bilaterally synchronous. So somebody's thrashing about asynchronously. That's not GTC. When you see them, they'll jerk symmetrically. In fact, you'll see that all limbs, even the eyelids, all jerk synchronously. GTC typically lasts 1 to 5 minutes, even though when you're actually watching one, it seems like it's a lot longer than it really is. So if family will come and say, it lasted 20 minutes, but they lasted 2 minutes. Injuries common, so they'll typically bite their tongue, usually on the sides of their tongue, as opposed to the tip. They may be incontinent during the seizure, and then afterwards they're always confused. They usually sleep, making loud snoring noises, and they'll wake up minutes, sometimes hours later. You can have generalized clonic seizures. There's no tonic phase at all. Go straight into the clonic phase. Okay? They lose consciousness. If they have a generalized clonic seizure, they tend to be shorter than generalized clonic seizures, and they also tend to recover more quickly. You can also have generalized tonic seizure, where you just stiffen up, and then that's it. And then you recover. There's no tonic phase. And the tonic seizures also tend to be brief, less than a minute, and they also recover very quickly. Again, they lose consciousness during the actual seizure in and of itself. Myoclonic seizures. So myoclonic jerks are brief lightning jerks, and you've all had them. You're falling asleep unless your head kicks out embarrassingly. So that's a myoclonic jerk. Seizures can present as myoclonias. Myoclonic seizures, when they occur, they tend to be bilaterally symmetrical, very brief. Patient does not lose consciousness. They're awake. Myoclonic seizures tend to occur more commonly during transitions to sleep, so when somebody's waking up from sleep, when they're falling asleep, just in some ways kind of unfortunate because that's when benign myoclonic jerks tend to happen too. Now, in people with myoclonic epilepsy, sometimes they can have what's called crescendo myoclonus. So before they have their GTC, they start getting more myoclonic seizures, increase in frequency and severity. So they go, oh, I have a GTC, so they'll go lie down in preparation for the GTC. Okay. And then lastly, atonic seizures. So loss of muscle tone, so-called drop attack. Drop attack is non-specific and you do a lot of different things. But so this is where you lose muscle tone, and there's a spectrum. So it can be a sudden head drop, especially like heads, or it can just fall to the ground, almost like a cataplexy attack. As you can imagine, injury is common with these types of seizures. They just fall without any warning. So, these are the you may see in group wearing helmets all the time, prevent head injury. Atonic seizures tend to be much more common in mentally handicapped population. And so that's it. So going back to our woman, so what's her diagnosis? Well, based on the description, she has focal impaired awareness seizure, the staring episodes, and sometimes she gets focal bilateral tonic-clonic seizure, which has convulsive movement. And because she's had recurrent episodes, there are no triggers, she does meet the definition of focal epilepsy. All right. So she says, great, doc. So what now? So how would you evaluate her? Well, it's just like anything else in medicine, right? No mystery here. History, exam, diagnostic test. And just like anything else in medicine, most of the time history is going to be the most important section. I suppose what the problem with seizures or epilepsy is that patients sometimes can't tell you what happens. Having a witness is very helpful. You can do the neurological exam to look for any kind of neurological deficits, although most of the time patients with epilepsy have normal neurological exams. You can do a lab test, CBC, CMP, you're going to make a mock screen, you may consider doing a pregnancy test if it's a woman. Then you do diagnostic tests, EEG, brain imaging studies, you may consider special studies, and you may consider doing video EEG. We'll talk about this in more detail. All right, so when you see somebody comes into your room and they say, oh yeah, I pass out, it's usually down to, was it syncope or seizure most of the time, especially in like medical clinic setting. And with careful history, you can sort of tease them apart pretty easily. Okay? With syncope, you should have the pre-syncopal symptoms and so forth. They don't tend to be that long. People recover very quickly. One entity that you guys should all be aware of is convulsive syncope. Hopefully you guys know about that already. Convulsive syncope is where you faint, because there's insufficient blood flow to the brain, but if that hypoxemia is severe enough, the nurse can actually stiffen up and have convulsive movement due to the hypoxemia. When somebody has convulsive syncope, however, the convulsive movements are short. Usually they last a few seconds and it's over. And so everything about the episode sounds like syncope, except that they stiffen up, they shake a few times, and then they wake up. Do not confuse that with GTC. You guys have seen GTCs. I mean, they last longer, very dramatic. With convulsive syncope, it's shorter and the person recovers very quickly. But I'll tell you that a lot of people are not aware of convulsive syncope, including medical professionals. I've seen a lot of patients, nurse said I had a seizure and on the plane and so forth. I've gotten calls from phlebotomy lab. Phlebotomy person had a vasovagal. They had convulsive syncope. They said, oh, new onset seizure. Call from endoscopy suite, different places. And so just be aware of the entity. So I'm going to tell you a little anecdote, but the time we'll skip over that. Everything else here, you can tease them apart. Last entity is psychogenic non-epileptic seizures, pseudo seizures. Just one comment about that. Obviously, these are patients who don't have any kind of brain abnormality to cause their seizures, unquote. But keep in mind that most of these patients are thought to be somatoform disorders, they're conversion disorders, so they're not doing it on purpose. As far as the patient is concerned, they still have no control over these things. So it's like an epileptic seizure. It's just that the underlying etiology is different. It's only a small percentage of people that are thought to be true malingerers who are making it for some secondary gain. Patients with PNES, as it's called, they tend to be more common in women. We don't know why. But there's also a high incidence of prior abuse, sexual and/or physical abuse. But because there's no abnormal brain activity to suppress, these patients don't need treatment with AEDs. They need AEDs. Psychiatrists try to figure out what the underlying psychological trigger is. Okay. So if you see somebody with pseudo-seizures, don't say, you're crazy, get out of here. All right. So you're seeing somebody with suspected seizures. Well, you're trying to verify that, number one, they have seizures. Number two, what kind of seizures do they have? And so these are some of the questions you're going to ask. So, you're getting kind of warning. What happens during the seizure? What happens after the seizure or the episode? If you've had more than one, I mean, is there any kind of pattern to it? Does anything precipitate it? I mean, every time you have alcohol, does it cause it, for example? When did it begin? Especially if you're concerned about genetic syndromes. If you've been treated before, what happened with the treatment and so forth. Especially, again, looking for possible causative factors, prior stroke, prior brain injury, and so forth. One word about head trauma. Based on the literature, it seems like you have to have a history of significant head injury to increase the risk of developing epilepsy. And so what's significant? Generally, it's meant either loss of consciousness for more than 30 minutes, any kind of skull fracture, any kind of intracranial bleeding, or confusion of the brain. I raise that because if you see somebody with new onset seizure or epilepsy, ask them, did you ever hit your head? 9 out of 10 times, they're going to say yes. When I was a kid, I fell off a swing, or my brother pushed me down the stairs, whatever. But then you have to ask them more. Well, did you pass out? Did you take in the hospital? Did you have a skull fracture? Because everybody's hit their head at some point in their life. Okay? And for those of you who have kids, you see toddlers are always falling and bumping their head on things. So don't attribute everything to traumatic epilepsy or post-traumatic seizures. Family history can be important if you think there's a genetic cause, and a psychosocial history, especially if you think there's a psychogenic component to the episodes. Now, if you happen to see somebody having a seizure, first thing to do is just take a deep breath and relax. This is your chance to kind of observe the seizure. So during this ictal phase, during the seizure, you want to protect the patient and check their mental status. Even if they're convulsing away, so still ask, alerting questions. You may say, name, give them phrases to remember. I'll say, remember red, white, and blue. Because sometimes you'll be surprised what they remember afterwards. And you can see if there are any kind of lateralizing features during the seizure. They just start on one side, for example. That'll give you a clue as to the type of seizure the person might be having. And then what happens after the seizure? Somebody has an apparent grand mal seizure, generalized tonic-clonic seizure. They're just convulsing away and then stops and they wake up and say, oh, I feel okay now. Okay, that's to raise a big red flag, right? So what happens after the seizure? How long does it take? Any kind of focal or lateralizing signs, so the TODS phenomenon. There's a TODS paralysis, which is a transient hemiparesis following a seizure, right? So if you have a TODS paralysis, that tells you it's a focal onset seizure. And if you have a TODS paralysis, that person has an underlying structural abnormality in the brain until proven otherwise. I guess you have to really look. But you can have other focal findings. I like to call it TODS phenomenon. So a person can have transient aphasia, for example, transient hemisensory loss, whatever it might be. But these things tend to resolve usually after minutes, sometimes hours, very, very rarely days. I've had one patient in my career who remained aphasic for 3 to 4 days after a seizure and then recover. If you give them phrases to remember, to ask about them. Okay. By the way, so when somebody's having a seizure, most seizures will end in minutes, only before 5 minutes. So if you see somebody having a seizure, you don't have to go running for Ativan right away and give them Ativan, because by the time you get the Ativan, the seizure will have ended. By the time you give them the Ativan, now you're sitting the patient for the next 30 minutes to an hour. Right? So just watch them. If the seizure is ongoing for more than 5 minutes, then you should treat them with Ativan. And that's really the practical definition of status. The seizure that's lasting more than 5 minutes, not the epidemiologic diagnosis, the duration of 30 minutes. So those things, just protect the patient, watch the seizure. Yeah, you can get the Ativan ready if you want, but don't automatically inject the Ativan, because odds are the seizure will stop before you give them the Ativan anyway. Diagnostic tests. Well, I mean, EEG is really one of the most important tests to do in somebody with suspected seizures. couple things to keep in mind. When you do an EEG, and I'm talking about a routine EEG, you're not trying to catch a seizure because a routine EEG typically lasts about 30 minutes recording time. The chance of that person having a seizure during that 30 minutes is pretty low. But in people with epilepsy, in between their seizures, they can have the so-called epileptiform abnormalities, so-called spikes or sharp waves. They mean the same thing. And so if you see spikes or sharp waves, that has a very high specificity for epilepsy. So that's what you're looking for. Now, in people with epilepsy, they have these spikes or sharp waves at varying frequencies from person to person. So some people with epilepsy, they never have them in between their seizures. Some people have them all the time. So this can be a sampling issue when it comes to routine EEGs. So it's been said that if you do one EEG, you have maybe 50% chance. By the time you get to your third routine EEG, you have about a 90% chance of picking up spike sharp waves if they're there. The problem is after that, it kind of plateaus. So it never reaches 100%. So the bottom line is that what that means is that a negative interictal EEG never excludes the diagnosis of epilepsy. Doesn't help you at all. Always treat the patient and not the test. About 2 to 3% of the population may have spikes or sharp waves on EEG, but never have a clinical seizure. So somebody's doing something funky and an EEG not indicating that comes out with spikes, don't assume that's seizures. It could be something else. And if you're sending somebody for a routine EEG because you think they're having seizures, liquefy them. Ask them to stay up the night before. That will increase the yield of the test. To bring out the spike of sharp waves, maybe by about 20% or so. Okay. Now you can do video EEG monitoring, just prolonged EEG, right? So if a routine EEG lasts 30 minutes and you do a 24-hour overnight EEG, then that's the equivalent of 48, I guess, routine EEGs. We do video EEGs for other reasons as well. I mean, obviously, they do it to confirm diagnosis, confirm epilepsy diagnosis. Sometimes a person's having funny spells, you have no idea what these things are. Questions are they some unusual seizures. Sometimes we'll do it to pinpoint the epigenetic focus, especially for maybe surgery purposes. And you can do ambulatory EEG or ambulatory video EEG. The video EEG, the ambulatory video EEG is not available in this instance, not at MSW, but it's available at Union Square and other places. Okay. Imaging study. Yeah, every person with epilepsy, or every person really with a seizure should have an MRI. An MRI is better than a CAT scan. If you're seeing somebody in the emergency room and CAT scan is the thing you can get more quickly, that's fine. But if you're seeing somebody in an outpatient office, skip the CAT scan and go straight to the MRI. If you're looking for any kind of structural abnormality, the big stuff you'll see, obviously, on the CAT scan too, but the problem is, cortical dysplasias or so-called mesotemporal sclerosis, you're not going to see on a CAT scan. And those are not uncommon in somebody with epilepsy. And so it's an example of MTS, which is a coronal cut. So this is the hippocampus on the left side here. On the right side, the hippocampus is smaller, but also brighter in signal. Classic MRI features MTS. Something like this you're not going to see on a CAT scan at all. And MTS is the most common structural abnormality you tend to see in somebody with mesotemporal onset epilepsy. Let's skip over this. So how would you treat her? So you did all the tests now, how would you treat her? And if so, how would you treat her? So when do you treat seizures? Well, the chance of them having another seizure. I mean, that's the most important question, right? The chance is 0, then forget it, I'm going to treat you. It's 100% that you would treat. Are there risk factors that will increase the recurrence rate of that seizure? And then provoked seizures typically do not require treatment, except to eliminate the trigger. Okay? So somebody's a cocaine abuser having seizures, stop doing cocaine. Okay? You don't need seizure medicine. I mean, there can be exceptions. In alcoholics, there's always a question, okay, they're not going to stop drinking, so what do you do then? Treat them, that's fine, but odds are they're not going to be compliant anyway, so it's a mood issue. All right. So, chance of having another seizure. Well, if you have one unprovoked seizure out of the blue, There have been lots of studies, but it's been pooled too. Chance of you having a second seizure, again, assuming the evaluation is normal, is roughly 1 out of 3 in the next 4 to 5 years, which means that there's 2 out of 3 chances you won't have a second seizure. So that's where the common practice of not treating after the first seizure comes from, meaning that this is okay. Now, if the person's not normal, so they're, let's say, mentally handicapped, they have cerebral palsy, they have what's called generalized spike wave on EEG, because the generalized spike wave, that's a common correlate of absence seizures, and so their first, quote, seizure, quote, may not be their first seizure. They could have had subtle absence seizures that weren't aware of. If there's a very strong family history, reactive seizures skip over, and if they have a positive phenomenon just because of the high correlation with the intellectual abnormality, then your recurrence rate is going to be much higher. And so in that situation, you need to treat after the first seizure. So the bottom line is that if you have epilepsy, and we went over the definition, then they should be treated. If you have epilepsy and you don't treat, the chance of recurrence is going to be at least 60%, it'll be more like 70 to 90% without treatment. So, well, if you do decide to treat, what do? Well, you're going to make sure you have the right diagnosis, and hopefully the right seizure and epilepsy classification diagnosis, and you try to pick a drug that's good for that of epilepsy. We generally aim for monotherapy, one drug, as much as possible for compliance and side effect issues. So I just listed all these drugs. There's new drugs and middle-aged and very old drugs. Is that there are over 24 medications available for seizures on the market, and so you should at least play with them. But, you have to know every nuance, the details of each one. Patients sometimes ask, are the new drugs better than the older drugs? From an efficacy standpoint, generally not. The newer drugs may be better tolerated in terms of side effect profile. Some of the newer drugs tend to have fewer interactions with other drugs. And then the newer drugs tend to have, it looks like at least lower risk of certain types of birth defects. So if you're starting somebody new, then you probably want to use one of the newer drugs. You're not going to put somebody on phenobarbital. But that even the older drugs still work from an efficacy standpoint. I'm going to skip over this. It just shows you that the ILA went through this whole literature search and tried to come up with level A, B, C, D in terms of the strength of scientific data. And the point is that that there are some paucity of studies. So even all the drugs that are on the market work, but in terms of level A, beta, and so forth, there's a lot of lacking information. And in kids, there's none. The drug companies do any studies in kids in general. Women who are taking seizure medicines, if they become pregnant, they do have an increased risk of birth defect. It's about a 2-fold increase. But the absolute increase is only about 1 to 4. 2-fold relative increase, 1 to 4 absolute increase. So the general population chance of having any kind of major birth defects is about 0.4%. It depends on the mom's age, family history, genetic conditions, and so forth. In women with who are taking seizure medicines, it's 2 to 8%, okay, which means that there's 92 to 98% chance that babies can be perfectly fine. Anyway, all the seizure medicines are thought to be pretty comparable in terms of birth defect risk. Probably the 3 drugs that you should avoid. Depakote, valproic acid, is the one that you should avoid definitively. That's the one that's been shown over and over again to have increased risk. In fact, valproic acid will actually have a persistent effect on the kids' IQ that is following them, but kids who are exposed to valproate in utero persistently have a lower IQ compared to controls through the elementary school years so far. Barbital and then topiramate, to some degree, topiramate has an increased risk of cleft lip, cleft palate. Okay, so those 3 I would probably avoid, but everything else is pretty comparable. And so, would you treat her? Yes. I mean, she has epilepsy, so you should treat her. And you can choose a drug that's appropriate for focal epilepsy. The reality is that you can really use any drug on the market for focal epilepsy. Probably the only exception would be ethosuximide, Zerontin, which for absence seizures doesn't really work that great for focal epilepsies. And then because she's a young woman, I'd avoid valproic acid, phenobarbital, and topiramate. And she says, okay, how long do I take medication for? is usually the next question. Okay, so just guidelines, if you have to stop medications, you do it slowly, take one drug away at a time. Perhaps the most cool study is this Medical Research Council study. This is done a while back now, but they had a bunch of adults and kids with epilepsy, 1,700 or so. Only about 1,000 were randomized to drug withdrawal or not. Others were not randomized. In this population, they were all seizure-free for over 2 years. Okay? And the medication was tapered off over 6 months. Breakdown. The bottom line is that in the randomized group, 40% of the patients who were taken off medication had a recurrence. And of that 40% have had withdrawal, had the seizures during the withdrawal phase, which is the first 6 months. The others had it after the 6-month period. Keep in mind that even patients who were not randomized have 20% recurrence rate. So if somebody has been seizure-free for at least 2 years, and they don't have one of the genetic syndromes that we know are lifelong, and assuming that they're okay, they probably have about a 6% chance of being able to come off medication successfully. It's a little better than a coin toss. And so you have to discuss with patients about what they want to do. I've had patients at both ends of the spectrum. I've had patients who are seizure-free for 10 years that I leave it alone. My cat was having a seizure. I don't want to, don't touch the medication. And I have other patients, they say, okay, it's the 2-year mark today. Can we start taking the medication off? Okay? And so talk with the patient, and I just give them the percentages, and then let them decide what they want to do. This is just kind of odds ratio of having a seizure, comparing the patients who are taken off medicines versus not. The interesting thing is that patients who are taken off medicines had about 3 times the risk of having a seizure during the first year. Then after that, chance of them having a seizure was no different based on medication. So it doesn't mean that they're going to be seizure-free. If you make it to the 1-year mark, then your chance of having a seizure off medicine is about the same as people who stayed on medication. Favorable predictors, basically the longer you're seizure-free, you tend to do better if you only need 1 drug. Have a higher chance of coming off medication, you are normal. And you don't have JME, juvenile myoclonic epilepsy. That's one condition where if you make that diagnosis, you need lifelong treatment period. You have a high recurrence rate off medications. So she should be treated for at least 2 years of seizure freedom, and then reevaluate. I would do an EEG and stuff, make sure everything is okay. Some patients need lifelong treatment, especially JME patients. And lastly, what happens if she takes the medication, but she's still having seizures? What do you do then? Well, then, the question is, does she have drug-resistant epilepsy? Well, drug-resistant epilepsy means that you failed 2 drugs. Okay. But it means that you failed 2 appropriately chosen drugs and at adequate dose. If you start it and then they have side effects, you can't start anything, that doesn't count. They have to have good trials of 2 medications. If that's the case, then if you have drug-resistant epilepsy by definition, and at that point you have to think about other treatment options. There's no time frame or frequency that's required to make the diagnosis of drug-resistant epilepsy. Some patients having 1 seizure a year is too many. Patients who have seizures, every other day. So it depends. But if they fail medication, if they have drug-resistant epilepsy, then you have to think about either epilepsy surgery, vagal nerve stimulation, responsive nerve stimulation, ketogenic diet, and so on. And so, if you're on medicine, can you have seizures? Then you should try another medicine, okay, as monotherapy or polytherapy. And then if it persists, at that point, I would say send the patient to an epilepsy center, taken care of. Okay, so conclusion. So seizure is not synonymous with epilepsy. Seizure is a symptom. Epilepsy is a chronic condition. Patients with nuanced seizure should be completely evaluated. Treatment does require knowing the seizure type and the type, and being able to use the right drug. Generally aim for monotherapy if at all possible. And then there's no set criteria for AED withdrawal, but as a general rule of thumb, you should not consider anybody off medication until they've been seizure-free for at least 2 years. And then medically refractory epilepsy patients should be evaluated for alternative therapies, usually by an epileptologist. That's it. Okay, I ran a little bit over, but any questions? Yeah.
Hi, this is Michael. I have 3 questions. One is the MRI, do we get it with or without contrast or both?
Yeah, we generally get an MRI with and without contrast. And if you specify seizure epilepsy, then they'll add additional sequences and they'll do extra thin cuts to the temporal lobe automatically.
Excellent. So when do we do 24 versus 4-hour seizures on the floors?
Yeah, EEG.
Yeah, I'm sorry, EEG.
Yeah, I mean, there's no set guideline. I mean, it comes. It's your choice in some ways. The reality is that, and this is sort of the practical aspect of medicine, insurance companies will not prolong the EEG monitor, whether it's inpatient or outpatient. Somebody's had a routine EEG first. So everybody should get a routine EEG. If the routine EEG is normal, and you still think the person might be having seizures at that point, it's reasonable to do a prolonged monitoring. I usually do an ambulatory EEG at that point, unless the person is complicated or I think possibly psychogenic, and I'll bring them in inpatient monitoring because you have better video, for it better. But if you're convinced a person has epilepsy, and the routine EEG comes back normal, sometimes I'll just treat the patient and then repeat a routine EEG down the road. I don't necessarily do an ambulatory EEG, but everybody does it a little bit differently, but everybody should at least get a routine EEG.
Okay. And do all epilepsy or seizure patients, should they get a neurology referral and it needs to be treated by neurology, or is there any case that it could be treated by medicine?
Well, it depends on how comfortable you are with reading them. And so...
Very uncomfortable, still.
So,
Great lecture, but still.
Yeah, so, yeah, it depends on your comfort level. I've seen both ways. Like, I'll see the neurologist right away. I have PCPs who will treat after a seizure, treat with the first medication, and then if the first medicine's not working, they'll say go see the neurologist at that point. As long as you can do the evaluation and you should comfortable making the correct diagnosis in terms of seizure type or epilepsy type, then that's perfectly fine. I think that neurologists, especially epileptologists, are more familiar with some of the nuances. So that, for example, we know that there's certain drugs in it that may not be good for certain seizure types. So, for example, somebody has absence seizures, then you put them on Tegretol or Leptal, that can actually aggravate absence seizures. Primary care doctors or even neurologists may not know that, so they put them on the wrong drug. Seizures get worse. And so, it's not to your comfort level. I suppose my bias is that, yeah, I think that every person with seizure probably should see a neurologist.
Cool with me.
Yeah.
Thank you.
Sure.
Hi, great lecture. I'm Kirti Pal. I'm one of the medical residents. We have a lot of patients sometimes who come in who are non-compliant with their medication and coming with seizures. One of the questions I've always had is how to decide how to load them at that point of time. Is there like a set criteria? Is it medication by medication, or what we've been doing is like kind of double the dose and then follow the levels the day after?
Yeah, there's no set criteria. There's no specific guideline. It comes down to medication. It comes down to how long they've been non-compliant, and so yeah, I sort of based on individual basis, depending on those criteria. So it's hard for me to give you a general answer in that kind of situation. Somebody missed a dose or two, then I'll usually do a small loading dose of what they missed and back to their maintenance dose. But if they've been off of it for a while, it comes down to the medication. So, for example, let's say they're taking lamotrigine. They stopped taking it a month ago. They went into the ER with a breakthrough seizure. You can't load them with lamotrigine. It's increased risk of rash and possibly Stevens-Johnson syndrome. And so that situation, they choose to put them on and back on lamotrigine. The problem with that drug is that it's going to take about at least 6 to 8 weeks to get to a reasonable level, or try a different medication in the ER and say, we'll load you with something else, and see how it works. But yeah, it really comes down to individual cases. It's hard for me to give you a general guideline. What I can tell you is that if they miss a dose or two, I'd say just give them whatever they missed. They missed longer than you can choose your drug and do a full load if you want. If the person's not having status, if you have time, just give them oral loads or even the IV load. If you give them too big of a load at one time, sometimes you make people sick, side effect. So that's something to be aware of.
All right, thank you.
The question. So just two questions, just for extra things. So one is it seems, of course, based on your presentation. So I think the most difficult syndrome will be the patient with the focal onset seizures who is aware, and that's probably the most difficult one to differentiate, for example, from someone with some sort of like psychiatric disease or non-epileptogenic syndrome, epilepsy. So what are some things that you use when you're witnessing these episodes to kind of help you differentiate between these two? So that's one question. And then the second question is that for kind of like a little bit off topic is on patients who come in with actual status. So I think it's been kind of like the classic understanding that benzos first and then sort of like some of the older drugs are more effective, particularly your fosphenytoin, your Depakote. There was a recent trial, I think it was published in Journal of Medicine, that showed that Keppra is as effective as all these other drugs. And I think based on my experience, we've been using Keppra preferentially for a long time. So what is your take on that?
Okay, so the first question about differentiating non-epileptic events from epileptic events, basically, especially when it comes to focal aware seizures. Yeah, that can be difficult. I guess just keep in mind that seizures occur because there's an abnormal electrical discharge in the brain, right? And so there's a physiologic base. And for most patients, they tend to have one. And so when they have clinical symptoms, the symptoms tend to be very stereotyped. Every episode thing. But somebody comes in having just different episodes, different times, they describe different things, and you start thinking, gosh, maybe it's not epilepsy. This person can have, I mean, you can, but it's very rare to have multifocal onset. So the lack of stereotypy, I suppose, can be one clue. Sometimes the duration can be helpful. So seizures tend to be brief. Focal seizures tend to last literally just a quarter of minutes. Somebody comes in there saying that I've had this in the last all day, lasts constantly for days and goes away. Odds are it's probably not a seizure. So those things can help you, but it is difficult. And even for people who appear to pass out and so forth, they used to do this, they don't do it anymore, but sometimes at the meetings, they'll have these symposiums and like pull the professor, they have show videos of events and say, seizure or not, without the concomitant EEG, and half the time they would get it wrong, say, no, that's not a seizure, it was a seizure. And so it can be difficult. And if there's a real question, then doing EEG monitoring is probably going to be your best bet to try to clarify the answer. In terms of status, I mean, that's a whole nother lecture in itself with status. But I mean, every society, the Critical Care Society, the American Health Society, they have specific algorithms, protocols for treatment of status. But yeah, benzo is the first line. Then after that, change a little bit, but you can use fosphenytoin, you can use alpha, you can use Keppra. Usually after benzo and then one of the AED stages go straight to an anesthetic agent, midazolam or whatever it might be, to the point even with so-called refractory status. And so I guess, when it comes to convulsive status epilepticus, the most important thing is just try to stop whatever you use. So, I mean, benzo is the first line, but after that, just try to stop whatever you decide to use. In terms of, and certain medications have been studied for status, but the reality is that most of the seizure medicines that are available on the market have not been tested specifically for status, so we don't have that big data, but they probably all work. Usually comes down to using this for the more conventional agents that are available in IV formulation. It comes down to most drugs are not available in IV formulations, so going to be used after the benzos, fosphenytoin, phenytoin, valproic acid, pecan, levetiracetam, those kind of drugs. So, and then phenobarbital is not used as much these days, and by that point we're going to midazolam's and the propofol already. So, yeah. So, I mean, I have. I don't want to go through the whole thing, but there is a. I don't know if I have the status algorithm. I have that. So this is the most recent status regimen, for, at least from the American Epilepsy Society, and it's very similar to the Critical Care Society. But initial choice is benzo, and then after that, it's your choice. Scientific literature data is class U, okay, which is unknown basically. They suggest you can use phosphatidyl valproic acid or levetiracetam. Okay. You don't have any of these available, you can go to phenobarbital. Those. And then if you're still having seizures at that point, again, there's no guideline, but that's the point, people go to the anesthetic agent. And so, so that's why you should suggest giving benzos and then either phosphatidyl valproic acid or Keppra. If you're still having status, then still seizing, then yeah, anesthesia.
Thank you.
Anything else? Okay, thank you.
Thank you very much.